So this lecture here is on the hematologic system for board review. The material was put together by Dr. Jonathan Waters, and I'm presenting it on his behalf. I don't have any disclosures. Dr. Waters' disclosures are listed below. So when we talk about the hematologic system, I'd like to break it up into three different categories. I think it makes a lot of sense to discuss it from a sense of pharmacology, from a sense of transfusion, and I think another big part of that is reactions to transfusion. So we'll look at each one of these in a lot more detail. My goal is to go over important board-relevant material related to pharmacology that will come up or could potentially come up as heavily tested or very frequently tested board questions or possible board questions, and then we'll get into transfusion medicines and medicine and reactions to transfusions. Of course, when we talk about pharmacology, we're going to talk about a number of different areas. We're going to talk about anticoagulants, antithrombotics, and antiplatelet drugs. Again, the mechanism of action should be something that should be known for the variety of these drugs. And of course, the board questions will ask you to take it one or two steps beyond that and discuss the comparison between different drugs or other antithrombotics or other anticoagulants. So which one would be better in a particular situation. We'll mention drug interaction, monitoring of side effects of drugs, and also toxicity of drugs. So again, and quite obviously, the board questions aren't going to ask you a particular drug's mechanism of action. It's going to want to know one step beyond that. So without going into too much more of an introduction, I think we should start by talking about some of the antithrombotics. First, there's antiplatelet drugs. And again, we'll go into more detail on about each one of these categories. But just very basically, antiplatelet drugs affect platelet function and primary hemostasis. And the prototypical example that we think of is aspirin for these drugs. Something I think is important is that these drugs in general are used to prevent arterial thrombi as opposed to venous thrombi. And these thrombi are predominantly composed of platelets, which is why the antiplatelet drugs tend to work more on the arterial side. This is opposed to anticoagulants, which again we will dissect and discuss in more detail. But just generally speaking, they affect the coagulation system and secondary hemostasis. The prototypical drugs that you might think of are heparin and Coumadin, and they're used to prevent venous thrombi. Again, venous thrombi, which are predominantly composed of fibrin. There's a number of oral antithrombotics that's worth mentioning. We'll start off with looking at some of the anticoagulants. I've listed both generic and the brand name for some of these drugs listed as anticoagulants. Remember that Coumadin, it inhibits vitamin K epoxide reductase. That alters the carboxylation of multiple coagulation factors, including 2, 7, 9, and 10, even protein CNS. And you'd reverse this with giving vitamin K to the patient. And I've listed various other numerous anticoagulants, as you can see, some of which we will discuss in more detail. And again, there's various antiplatelet drugs, which will also be discussed in more detail. Here are further summary lists of anticoagulants and antiplatelet drugs that are administered IV. We have heparin, we have fondaparinux, which is a Rixtra, bivalirudin, it's a direct thrombin inhibitor, and Angiomax is a brand name for that. And then we have other antiplatelet drugs, again, which are listed and which will be discussed in more detail. This is a nice overall depiction of the clotting cascade, which we've known since medical school and have gone over, but it doesn't hurt to take a look at it and review the various parts of coagulation and hemostasis. I think it's important to break up hemostasis into primary and secondary hemostasis. On the left, you'll see primary hemostasis. You'll see the effect of von Willebrand's factor and platelet adhesion, activation, and aggregation, all of which we'll discuss in the various drugs that interact to form the hemostatic plug. You also see secondary hemostasis, which we think of as tissue factor, the various coagulation factors, protein CNS, all of which come together with fibrinogen to, again, help with forming the hemostatic plug. But I think before we get into too much detail, it's always nice to see a general overall depiction of how hemostasis is affected, how plasminogen and plasmin affect fibrinolysis as well, too. So as far as primary hemostasis, there's three basic components, and the board relevant questions will come from what step or what mechanism of action affects what step. There's activation, there's adhesion, there's aggregation. When we think of activation, it's usually platelets become activated when they contact tissue factor or when they contact collagen, after there's been damage to the endothelium, or after they interact with thrombin. And there'll be a separate slide devoted to activation. Adhesion is with the use of the GP1A receptor on platelets or the 1B receptor on platelets, which adheres to the damaged endothelium. And then there's a step of aggregation, which involves the GP2B3A receptor, which causes fibrinogen to form bridges between platelets. And these agents, therefore, that inhibit the 2B3A receptor block ADP from binding to this receptor. Again, so aggregation, the 2B3A receptor in the drugs is listed in the slide here. This graphic here depicts a platelet bonding and binding to collagen or a damaged endothelium. You can see the 1B or 1A receptor that binds to von Willebrand's factor and allows a connection and allows the process of primary hemostasis to take place. You can see the various substances that the platelets secrete, such as von Willebrand's factor, ADP, and thromboxane as well too. So as far as the step of activation, there's exocytosis of various granules, including the dense granules, as you can see that's listed in the picture on the far left hand of the side, and there's alpha granules. The dense granules release ADP and contain ADP, and the alpha granules contain various proteins, including von Willebrand's factor, thrombin, and certain growth factors. And we'll talk a little bit more about the thrombin that's secreted from these alpha granules in just a minute. Aggregation is kind of an accumulation of these effects. Again, you can see the endothelial cell and the damaged area here. And basically, you can see the aggregation of platelets which takes place, again, with thromboxane helping to mediate this. You can see ADP and thrombin as well as mediators of the aggregation step. So now let's talk a little bit more about drugs and which ones affect which. Adhesion, we don't really have a whole lot of prototypical examples, and these drugs are still in the experimental phase. Activation, drugs are numerous, and they include drugs that inhibit the thromboxane pathway, such as aspirin. There's drugs that inhibit the ADP pathway, such as clopidogrel or Plavix. There's drugs that inhibit the thrombin, PAR1 pathway. Those are still in the experimental phase. The PAR1 pathway is a protease-activated receptor pathway, and basically these PAR1 receptors are on the surface of platelet, and thrombin binds to them and allows the conformational change and the structural change of platelet that leads to activation of the platelets. And lastly, there's aggregation, which abciximab is a drug that prevents aggregation. Again, this is a 2B3A receptor. Abciximab is a 2B3A receptor antagonist. This is a nice slide here that provides a general, broad overview, as we've all learned, the extrinsic and intrinsic pathway of the coagulation cascade, a fast and a slow pathway that then converge on a common pathway. I'd like to mention initially what normals are. Extrinsic pathway has normal prothrombin time or PT time of 12 to 14 seconds. The intrinsic pathway has a normal activated partial thromboplastin time of 25 to 35 seconds. So I think those are important to remember. And it's also remember the board could ask very particular or hidden questions related to what factor, and they might not label it with calcium. For instance, they could say factor 4. So I always like to review that factor 1 is fibrinogen, factor 2 is prothrombin, factor 3 is tissue factor, factor 4 is calcium. These are all things that are worth mentioning or writing down as you look at these slides here. That factor 4 is calcium, factor 2 is prothrombin, factor 1 is fibrinogen. Also remember, this slide doesn't necessarily pull in protein C and protein S. Protein C inactivates 5A and 8A, so that's something worth writing down. And protein S is a cofactor for activated protein C. So protein C and protein S are important to this coagulation cascade as well. And while we're talking about factor or protein C and protein S, I should mention the factor V Leiden thrombophilia. It's often mentioned as a deficiency, factor V Leiden deficiency, but it's actually a thrombophilia. Basically, this mutation in the factor V, known as factor V Leiden, it cannot then be inactivated by activated protein C. So basically, because factor V cannot be inactivated by protein C, you have excessive clotting. So I think that's something worth mentioning. Again, that could be a board question related to what actually is the mutation, or is it a deficiency with factor V? It's actually not. It's a thrombophilia. It's a mutation. This slide here just lists some of the various limitations of warfarin. Again, as we all know, it has a slow onset of action that necessitates overlap with a rapidly acting IV anticoagulant, such as heparin, when starting therapy if the dose needs to be rapidly titrated up to get quick anticoagulation. There's genetic polymorphisms, of course, that affect metabolism of warfarin. There's food and drug interactions. That's why warfarin needs to be monitored on a regular basis. And the other thing, there's a narrow therapeutic range of warfarin. So again, there needs to be regular coagulation monitoring. And some of the newer drugs that we'll discuss don't have that necessity for regular coagulation monitoring. So again, let's look a little bit more about the pathways that we've mentioned here. There's various drugs involved with both the extrinsic and intrinsic pathway. I should mention heparin. Heparin binds to antithrombin 3 to inactivate factors 9, 10, 11, and thrombin. I'll say that one more time. Heparin binds to antithrombin 3 to inactivate factors 9, 10, 11, and thrombin. Heparin has a rough approximation half-life of about 1 hour, and because it's working on 9, 10, 11, and thrombin, you can see the factors are involved. It's basically going to extend the prothrombin time and the activated partial thromboplastin time. While we mentioned heparin, I should mention heparin-induced thrombocytopenia, HIT, HIT. It's an antibody-mediated response which causes thrombocytopenia. It's an antibody that binds to platelets. And it can also lead to HITT, which is an extension of that, where the second T stands for thrombosis. While we're looking at the coagulation cascade, I should mention a few other possible deficiencies or hereditary genetic diseases that may be mentioned in a stem of a question. Remember that hemophilia A is a factor VIII deficiency. That's going to prolong the PTT, or activated partial thromboplastin time. Hemophilia B is a factor IX deficiency, and it's going to also result in a prolonged partial thromboplastin time. Something that's not shown on this initial slide here of the coagulation cascade is von Willebrand's factor, which is involved with primary hemostasis. And so I think it's important when you're giving a lecture on the coagulation cascade and coagulopathy and the hematologic system to mention von Willebrand's disease. There's various types. I think this is something worth writing down. There's type 1 von Willebrand's disease, which is approximately 70 to 80%, 60% of all von Willebrand's disease cases. This is a quantitative defect of von Willebrand's factor, and so the production of von Willebrand's factor is decreased. There's type 2, which is again 20 to 30%. This, on the other hand, is a qualitative defect of von Willebrand's factor, and the amount of bleeding between patients can vary. However, there are normal levels of von Willebrand's factor. It's just that there's a qualitative defect in the actual factor protein. And then there's type 3. It's the most severe form of von Willebrand's disease. It's characterized by the production of no, or the absence of von Willebrand's factor. And so I would mention the treatment. Again, desmopressin, DDAVP is often mentioned. However, it can't be assumed to be the treatment for all types of von Willebrand's disease. For instance, DDAVP or desmopressin can actually cause a drop of the platelet count for type 2B von Willebrand's disease. Other things that we should mention when we're looking at the coagulation cascade on this slide here, I would mention protamine. We need to talk about reversal of heparin, and protamine is a strong base that neutralizes heparin. So again, and this is something that's used all the time for cardiac bypass and when the patient's been fully heparinized. And it's an acid-base interaction that neutralizes heparin. But anytime you mention heparin, the board questions arise with the complications of heparin and the reactions to heparin. There's a hypotensive reaction that you can get due to rapid heparin administration, and that's simply due to histamine release. So the first reaction I would mention is hypotension due to histamine release. You can also have severe pulmonary hypertension, which can be catastrophic. And then there's an anaphylactoid reaction that can also happen to protamine. And the difference between anaphylactic and anaphylactoid reactions is another important question, whether this is an oral board stem or a grab bag question or a written boards question. Anaphylactoid reactions don't necessarily involve the antibody response, although a lot of the symptoms and side effects are the same, whether it's anaphylactoid or anaphylactic. And lastly, I should mention that protamine can cause a severe myocardial depression as well, too. So these are all issues with protamine reversing heparin. Let's move on a little bit more. Before I leave this slide, I want to mention a few other drugs or medications that can involve the coagulation cascade. There's direct thrombin inhibitors. Again, thrombin at the bottom here. These are things like dabigatran. It's a direct thrombin inhibitor. There are newer drugs that I think are important to keep in mind. And then there's also other medications such as rivaroxaban, apixaban, fondaparinux. These are all 10A inhibitors. And an easy way to remember, other than the fondaparinux, a lot of these newer generic names have XA for 10A in the name of the medication, which is helpful when you're trying to decipher it on an exam question stem. So rivaroxaban with a 10A or XA and apixaban. I should mention that fondaparinux works a little bit differently than some of these direct 10A inhibitors. Fondaparinux or Arixtra works through antithrombin 3, which is a little bit unusual compared to some of the other 10A inhibitors. So it doesn't work exactly the same. Also, let's talk a little bit about fibrinolytics. Remember that plasmin degrades fibrin and breaks down clot. There are various drugs that therefore can either inactivate plasmin or activate plasmin. Urokinase is a drug I wanted to mention. Urokinase actually helps the conversion of plasminogen to plasmin, so that is going to help break down clot. And I wanted to mention the tranexamic acid at some point as it relates to fibrinolysis. Basically, TXA or tranexamic acid is an analog of lysine. And so this molecule or this drug is going to bind to plasminogen and plasmin and inhibits its action. So it's going to stop fibrinolysis. So the opposite of urokinase. So think of urokinase and tranexamic acid as opposites and have opposite mechanisms of action. So I'm going to skip this slide. It talks a little about rivaroxaban, which we've included here for your background knowledge, if you want to refer to that, and dabigatran, mechanism of action for that. And I want to, at this point, go into a discussion on transfusion medicine. So there are various indications there for transfusions, which we'll discuss, and I want to go over some of the studies that Dr. Waters had placed in these slides that discuss when transfusions are necessary. I want to go over blood preservation and storage, filters and pumps. We'll talk a little bit about, and the effects of cooling and heating. It's important to talk about the components of blood. Again, I just want to give a very introductory slide so you know where we're going with transfusion medicine. We'll discuss the difference between a type and a cross and a type and screen, the amount of time it takes to complete both, autologous blood, and we'll briefly, very briefly, mention at least that there are synthetic and recombinant hemoglobin options available, although they're not in wide use in a lot of situations. So what about indications for red blood cell transfusions? These could very well pop into a board question related to if a patient should or shouldn't be transfused. So each red blood cell unit is collected from an individual donor whose hematocrit or hemoglobin, actually the hemoglobin concentration, is supposed to be greater than 12.5 grams per deciliter. The volume collected is also specified on the unit, usually either 450 to 500 milliliters, but it can vary by up to 10%. And there are losses in processing of the blood units, and for instance, leukoreduction may result in the loss of some of the volume. So the end result of the donor collection processing variability is that the volume of a red blood cell unit usually varies from 150 to 250 milliliters of red blood cells. And the hemoglobin content is usually anywhere from 40 to 70 grams. But keep in mind that the size of patients creates considerable variability than the initial 10% that you might mention. And just as a general rule of thumb, the clinical rule of thumb is that a unit of red blood cells should raise the hemoglobin of a recipient by about 1 gram per deciliter. So that's a relatively useful starting place, 1 gram per deciliter for a unit of red blood cells. And again, if you have a morbidly obese patient, that's going to, of course, adjust the amount that their hemoglobin is going to increase due to the morbidly obese patient's increased blood volume. Now let's move on, and I want to look at a study here to help kind of illustrate the point of when patients should or shouldn't be transfused. This study by Hebert is involved with assessing red cell needs in critically ill patients. This study has done the most out of the many studies that have been done to elucidate the effect of different transfusion triggers. This was a multi-center, prospective randomized controlled trial, and basically it looked at transfusion on various triggers. There was a restrictive trigger that was used with maintaining hemoglobin from 7 to 9 versus a liberal transfusion policy or transfusion trigger where when a patient's hemoglobin reached 10, they would be transfused, 10 grams per deciliter, that is. And the other important component of this study was that these patients were volume resuscitated and normovolemic, so that eliminates another variable or bias in these studies. So these two groups had very similar degrees of illness acuity as defined by the Apache scoring system as labeled here. So basically, when you look at the survival curve, I think it's rather easy to illustrate the difference. When patients are given more red blood cell products, as indicated by a liberal transfusion strategy, the survival tends to branch off, especially 10 days to 15 days further down the line in this ICU patient population with similar Apache scores. And again, there are various reasons why, but clearly patients who are under a more liberal transfusion strategy are having worsening survival outcomes from the 0 to 30-day point. Again, if you subdivide this for patients who are younger than 55 years, a similar statistically significant result is noticed. And again, this with a p of 0.02, you can see the lower survival curve for the liberal transfusion. And again, this is defined liberal by transfusion of a transfusion trigger of 10 grams per deciliter hemoglobin, restrictive at 7. This table here shows some of the differences. This was a subgroup analysis of patients with ischemic heart disease. It was performed later to patients who were enrolled in this study. The study wasn't designed or powered to look at this question directly, but a secondary analysis was offered by the authors in an effort to shed some light on the effect of anemia in this population. And there was really no demonstrable difference between the two groups. You can look at the p-values here in any of the primary outcome measures. And again, this is particular to ischemic heart disease patients. So regardless of their being transfused liberally or restrictive, they were seeing relatively same outcome measures. Similarly, the transfusion trigger used did not alter the ventilatory support needed by these patients. So really the bottom line is the concept of transfusing a patient in order to wean them from the ventilator has not been supported by this data. Again, all not statistically significant. One further slide, one further study to show you. This is the FOCUS trial. It looked at liberal or restrictive transfusions in high-risk patients after a hip surgery. And I'm not going to go into the specifics of this study. I don't think it's necessarily important for a board review course to know this individual study, but the results of which I think you should. This transfusion threshold was 8 and 10 instead of 7 and 10 from the previous study. Again, I'm going to skip over the demographics and the variables involved with this study. And what I do want to go to is the recommendation then. The recommendation of the American Association of Blood Banks, the AABB, recommends adhering to a restrictive transfusion strategy, a trigger of about 7 to 8 grams per deciliter, in hospitalized, stable patients, and patients should be transfused 1 unit at a time and then reassessed as the need is seen. And again, this was given a strong recommendation, high quality evidence grade as far as the recommendation for this. So when should plasma be transfused or FFP be transfused? In what patient populations? This study looks at, by Dr. Yu, looked at bleeding time for liver bleeding time in relation to PT, platelet count, whole blood clot time, length of biopsy cylinder, the histopathology of the liver surgery, and basically no correlation was seen between any of these variables that I just mentioned, such as platelet count, PT, length of biopsy cylinder, and bleeding time. Bleeding could actually be easily stopped by compression. So there's been multiple studies that have shown, again, there's been more recent studies even that have shown that no correlation has been found between observed liver biopsy bleeding time and platelet count or PT ratios. So it makes us wonder the necessity, or why, or do we actually need to give as much FFP or plasma as we think we do. So basically, the data from this study and other studies supports the conclusion that mild to moderate coagulopathy does not appear to be associated with prolonged bleeding time, specifically for liver biopsy. And we'll talk about other patient populations as well too. And that normalizing these coagulation studies does not necessarily indicate an absence of risk for liver biopsy bleeding. Again, normalizing these coagulation studies does not indicate absence of risk. So I want to move on actually, and I have a slide here for reference from Holland's study, but I want to look at this study here by Holland, which basically looks at the per unit of plasma transfused and the change in INR. And Holland did a nice study, and I have the citation down if you want to refer to the initial study. But from a board review perspective, I don't want to get into the specifics other than mention that when plasma and FFP is being transfused, a lot of the orders are unnecessary. And the most frequent reason for inappropriate orders is for correction of a prolonged INR in the absence of bleeding. And basically you can see when the INR was greater than 1.6, as denoted by these open circles here, the INR did change significantly when giving a unit of FFP, or a unit of plasma. It changed, it might have gone down a half, it might have gone down 1 or 1.25 or even 1.5 in this patient here, as opposed to when the initial starting INR was less than 1.6, giving a unit of FFP didn't really alter the INR that much, very little. And so in fact, if you have an INR that's right around 1.5 or 1.4, you can pretty much bet that giving a unit of FFP isn't going to alter it dramatically, as opposed to patients who start off with higher INRs. So there's reasons for why physicians and providers are prescribing FFP, and it might not necessarily be indicated. And these reasons including thinking that the elevation of the PT and INR will predict bleeding in the setting of a procedure. Pre-procedure administration of FFP will correct the prolonged clotting time. And the other reason that physicians are prescribing these is that they think the prophylactic transfusion of FFP will result in fewer bleeding events. A lot of these which haven't really been proven clinically. And so I would mention that although there's little doubt that FFP transfusion can be effective at correcting laboratory abnormalities under the right circumstance, the data from this study by Holland shows that the most important variable in determining the amount of change in the INR with FFP pre-transfusion is the pre-transfusion INR, as leveled by greater than 1.6 or less than 1.6. So it's something to keep in mind. The study actually showed that the pre-transfusion INR actually accounts for as much as 82% of the variability in the INR following FFP transfusion. So again, that's something that's important to keep in mind. So why am I mentioning this? Well, we might not necessarily need to give as much FFP or factor as we think, because there's a zone of normal hemostasis. When your INR is slightly elevated, you still have a physiological reserve. This graph here shows is denoted by the 30% line. And so just because the INR is elevated, the body has still extra and enough to complete the normal secondary hemostasis and primary hemostasis to form a hemostatic plug. So let's move on past these arrows and basically come to a conclusion, which shows that the bottom line is imprecise. And what I would say is most patients with a hemoglobin less than 7 will benefit from transfusion. Most patients with a hemoglobin above 10 will not. Most patients, however, when you're making this decision, you're going to fall between these limits. And until additional data are gathered to address the myriad clinical situations in which transfusions may be beneficial, we have to really combine the science available with the traditional art of medicine that we use to determine when plasma should be transfused. I would also mention a couple things from this slide here. Remember, factor 7 has the shortest half-life of all the procoagulants, about 5 to 6 hours. So sometimes, if you're going to give FFP or factor or plasma the night before a procedure, 6 hours later, a lot of this factor 7 is going to be disseminating, is going to be evaporating, and not necessarily evaporating, but diffusing away and being degraded, and so you're not going to really get a whole lot of effect from it. A 250 milliliter unit of plasma may be able to provide about 200 units of procoagulant activity. So I do want to, again, stress the importance of the shortest acting half-life procoagulant, which is factor 7. Now let's move on to discuss platelet transfusion. No definitive statement of prophylactic transfusion criteria has been established in the United States. There has been a British group that suggested that 10,000 platelets per microliter trigger is appropriate unless there are additional risk factors such as sepsis or an impending invasive procedure. Of course, neonates may benefit from a higher threshold, often stated at 50,000 or 100,000 per microliter, and again, that's to avoid intracranial hemorrhage. The importance of maintaining the patient's hematocrit to force platelets to the periphery of the vessel so that they can come into the contact with the endothelium was also emphasized. For patients who are bleeding, a platelet count of 50,000 per microliter was recommended, although there were no prospective trials addressing this issue. The group in this study also noted that platelet transfusion was appropriate in idiopathic thrombotic purpura, ITP, only if there were significant hemorrhage, ITP. So let's look at this graph here. Schlichter and Harker in this study took a more direct approach in attempting to define the level of thrombocytopenia that was clinically important. They administered radioactive iron to patients who are going to receive chemotherapy, and then they quantitated the amount of gastrointestinal blood loss by measuring stool radioactivity. And they noted a marked increase in blood loss only when the platelet count reached 5,000 per microliter. In the last decade, several papers have documented that a prophylactic transfusion threshold of 10,000 per microliter is well tolerated by patients and does not lead to an increase in severe bleeding. All of these studies have associated this more restrictive trigger point with reductions in platelet usage that is not accompanied by an increase in red cell usage or hemorrhagic outcomes. So one approach that has been trialed is the identification of patients at high risk for bleeding and the application of a higher trigger point in this group. Let's talk a little bit about massive blood loss and massive transfusion. Massive blood loss is usually defined as a loss of one blood volume within a 24-hour period. A normal adult blood volume being approximately 7% of ideal body weight, or 8 to 9% in children. There's alternative definitions for massive blood loss. It could be 50% of the blood volume within 3 hours, or a rate of loss of 150 milliliters per minute. And really, such definitions emphasize the importance of early recognition of major blood loss and the need for effective action to prevent shock and its consequences. Of course, priorities for treatment are achieving hemostasis by treating any surgical source of bleeding, correcting coagulopathies by using the appropriate blood components, and restoration of blood volume to maintain tissue perfusion and oxygenation. An interesting or a meaningful fact here is that a platelet count of 50,000 per microliter is usually to be anticipated when about 2 blood volumes have been replaced by plasma-poor red cells. But again, with anything, there's marked individual variation, but usually 2 volumes of blood unit replacement or blood volume replacement, that's blood volume replacement, leads to a platelet count of about 50,000. Expert consensus argues that platelets should not be allowed to fall below 50,000 units per microliter, or platelets per microliter, in acutely bleeding patients. A higher target level of 100,000 per microliter has been recommended for those with multiple traumas or central nervous system injuries. Now I think is a good point to move into reactions to transfusions. Again, there's a whole list of various reactions that we have here. There's febrile, there's allergic, hemolytic. Some of these we'll talk about. Some of these are infections that are sequela of transfusions. There's citrate intoxication. We all know that citrate binds calcium and can lead to increased bleeding times. And again, there's various other effects such as trolley and taco. Again, number 8 and 9 listed here, which we will discuss. You can break this into acute and delayed reactions. I'm not going to go over and list everything that's listed on the sides, but for board review purposes, I think it's important to mention these. We will divide for this presentation a transfusion into these 2 groups of acute versus delayed. Delayed meaning shortly after, or acute meaning shortly after surgery, and delayed meaning days, months, or years later. The delayed reactions are usually diagnosed as diseases or syndromes and secondarily related to the prior transfusion. This is another way to look at dividing these up. There's immunologic, there's infectious, and there's metabolic reactions, both for acute and delayed types. Let's move on here, and I think it's worth mentioning the various components of some of the solutions, the anticoagulant solutions that compromise blood products. You can look at their acidic pH. I think that's important to denote. You can see the exact composition of the adenine, of the citric acid, of the phosphate, and the dextrose that's in it. Look at the high concentrations of citrate that are used, and the amount of citrate varies within certain blood products here. This is another slide that shows some of the different components that are in these various constituents that are in the various additive solutions for your reference. Again, I think this is a very easy to point out using this graph. It's easy to illustrate that as storage time increases, potassium levels can also increase. But then again, regardless of storage time, you're going to denote a significant amount of hyperkalemia. Leukocyte-depleted blood moderates immune modulation, and because white blood cells harbor viruses, leukocyte-depleted blood is thought to decrease the viral load to a patient and thus further reduce the infectious risk. I should also mention postoperative jaundice here. Approximately 20% of blood undergoes hemolysis within 24 hours of transfusion, and each half-liter unit of blood stored in CPDA1 blood yields approximately 7.5 grams of hemoglobin, which is then converted to bilirubin. And so therefore multiple units of blood can therefore overwhelm the body's ability to conjugate and excrete bilirubin. So I want to move past a couple of this picture here to show you a picture of contaminated platelets. Again, remember the platelets are prone to infection, as there are other blood products, but specifically platelets. This unit here actually was growing Klebsiella pneumoniae, and it was also positive for other gram-negative organisms. As you can see, the expansion And even though no source of contamination was determined in this donor unit, which was a 19-year-old female, and there was no data to suggest that she was bacteremic, and the blood was collected in a sterile environment, it is possible to get infections in these units. Clostridium, Klebsiella are two of the most common gas forming bacteria, and so again, this unit was discarded as the pouch was puffed out, denoting the gas formation. What about infection risks with various blood products and testing? First, let's talk about testing. There's a surface antigen that can be checked for hepatitis B. There's hepatitis C antibodies. Again, there's nucleic acid testing for HIV-1, which can tell you earlier in the infective stage if a patient is infected with HIV-1, as opposed to waiting for antibodies, which are a little bit later. Again, there's various serologic testing for a lot of the different infectious diseases. What about risk? This, again, is a board question that pops up from time to time, or it could be a possible point of discussion. HIV, has 1 in about 2 million chance of a risk of HIV with a transfusion. HCV, 1 in about 2 million as well too. And look at hepatitis B, 1 in about 200,000. So that's an important point to mention for boards. Hemolytic transfusion reactions happen about 1 in 10,000, 1 in 12,000 units. It has a very significant mortality, as you can see, 20 to 40%. Fatal reactions are approximately in the order of 1 in 30,000 to 1 in 100,000. So these vials here represent serum hemoglobin after a hemolytic transfusion reaction. You can see the pre and post transfusion vials are labeled. This was a 22-year-old who presented to an emergency room with pelvic pain and shock. She was found to have a ruptured tubal pregnancy. Basically, blood was drawn, and the lab tech ended up getting the samples confused, and the patient was transfused 2 units of the wrong type. And although it was readily identified, and the patient was treated with large volumes of saline, bicarbonates, and Lasix and steroids, she did have an uneventful recovery, because even though it was transfused improperly, it was quickly treated. And again, this is a very, very critical, very serious, life-threatening injury, and luckily this patient, she did survive. So obviously critical actions include stopping the transfusion at the appropriate time, as early as allowable, and sending a post-transfusion blood specimen to the blood bank. As I mentioned here, these are all easy things that need to be done, but obvious, but maybe in deteriorating situation, things that you might forget. The 3 T's of transfusion: there's transfusion-related immunomodulation, but I do want to mention the second 2, trolley and TACO, transfusion-related acute lung injury and transfusion-associated circulatory overload. I think this graph shows a lot. As the number of units go up, the amount of infection goes up, whether it's spine fusion or whether it's trauma or cardiac surgery. This is another survival curve that shows the proportion of patients surviving based on the number of transfusion units for patients following hepatic resection for colorectal metastasis. Again, it's nice to illustrate the point of how transfusions can harm overall survivability. Again, more graphs showing for oral squamous cell carcinoma, survival curves, gastric cancer. And so really, there's a variety of types of patient populations that survival is diminished by transfusions. So now let's talk again about bullet 2 and bullet 3, trolley and TACO. Transfusion-related acute lung injury is now the most common cause of transfusion-related death. The new consensus definition of trolley is what's listed above. It's for patients with no other acute lung injury prior to transfusion, and it should be made, the diagnosis of trolley should be made within 6 hours after completion of the transfusion. And there's various factors such as acute onset of respiratory distress, hypoxemia, oxygen saturation less than 90%, other clinical evidence of bilateral lung infiltration, no evidence of circulatory overload, and no other acute lung injury risk factors like sepsis or like a lung contusion or a burn injury or a patient on cardiopulmonary bypass. And so I have this slide in here for your reference to produce a definition of TRALI. Again, here's a patient's chest x-ray. In this man, bilateral diffuse patchy infiltrates develop within 6 hours of receipt of a plasma-containing blood product. I put this slide in for reference as well, the difference between TRALI and TACO. Keep in mind, look, fever can be present with TRALI. It's usually unchanged with TACO. You can look at the PA occlusion pressures, which are different. You can look at the BNP, which is going to help differentiate between TRALI versus TACO. And again, it's an exudative versus transudative process. Permeability versus hydrostatic reasons for this. So now let's move on and talk a little bit about pre-transfusion testing. This here lists some of the various most common blood types, just for your reference, O positive being the most common. And as far as the difference between a type and a screen, I should mention, as this slide from Miller illustrates, that a type and screen, the patient's serum is taken and then placed in a vial with standardized type O red cells to look for a reaction. The type and cross takes it one step further, where after the type and screen has been completed, patient serum is then mixed with donor red cells, which is a cross match to look for a reaction. This just reminds you the various antigens that each blood group has. And remember, if a patient's blood type A, they have antibodies or anti-B antibodies and no anti-A's. Pre-transfusion testing looks at the expected antibodies of the ABO blood group type, and there's also all these different antibodies. There's over 600 red cell antigens to Kell, Duffy, KID, and I'll talk a little bit more about those that the screen can pick up on. These are some of these other frequently encountered clinically significant anti-red blood cell antibodies that can be picked up on potentially by doing these screens. So as far as time that it takes to do it, the ABO type can be known within 10 minutes. Antibody screen is 45 to 60 minutes depending on the technique. And cross-match can be anywhere from an immediate spin for 10 minutes to up to 45 minutes. So you can see, for your reference, here's some more information here. As far as risks of uncross-matched blood, you can see that there are rare events of hemolysis and there are a little bit higher rates of new antibody formation. I do want to mention a little bit of blood warming. There was a small study that was done by Dr. Koenig that shows that even though the study was small, there's a lot of discussion about platelet warming and if platelet warming is good or what are the effects of it. And basically this study the results of this study do not support the prohibition against mechanical platelet warming. And basically it was using thromboelastography to look at the effects of platelet warming. And so again, I will repeat, the results of this study do not support the prohibition against mechanical platelet warming. So in other words, these platelets could be warmed without significant deficits. So I do want to mention a few things about blood filtration. In the blood salvage system, the collection reservoir has a screen filter as indicated by the yellow line. The blood passes into the reservoir where it meets a filter that screens out particulate matter. The filter usually comes in two sizes. There's a 40 micron size, there's a 120 micron size. In other words, anything smaller than the 40 microns would pass through the 40 micron filter. Likewise, anything smaller than 120 microns would pass through the 120 micron filter. So at the reservoir level, it's generally best to have a large screen filter. Otherwise, blood can be trapped in the filter and unavailable for washing and readministration. This picture shows a magnification of the screen filter from the blood salvage reservoir. And again, I should mention that when I'm talking about filtration, we're talking about blood salvage. One can see the pore size of 120 microns and how it kind of resembles a window screen. This photo shows a depth filter. The arrows indicate the flow of blood as it passes through the filter. The filter shown here is a PAL-RS, P-A-L-L-R-S filter, which is designed specifically for removal of leukocytes. This filter is also good at removing materials such as amniotic fluid cells, cancer cells, or bacteria. Within the depth filter, there's packing of fibers as shown. When blood initially enters the filter, it is subjected to a fiber packing density as shown on the left. And then as the blood continues through the filter, the packing of the fibers becomes progressively tighter. 3 different types of filters are shown here. Each filter has a different role in blood salvage. The filter on the left is simply a screen filter used for microaggregate filtration. Most blood salvation equipment manufacturers recommend use of these filters with every unit of blood. The name SQ40 represents the square shape and removes 40 micron size particles. The filter in the middle is a mixed function filter, and then it has both screening and depth characteristics. The filter is most commonly used when fatty deposits contaminate the blood product found during procedures such as orthopedic procedures. And the filter on the right is a depth filter designed for leukocyte filtration. Several authors have demonstrated that filters like this are effective at removing other contaminants such as malignant cells. There's alternatives to transfusion. There's things like hemodilution, sequestration, autotransfusion, blood substitutes, and erythropoietin. And I just quickly want to discuss possible board questions or possible topics that the board might hint at. Not necessarily questions, but possible review material that is important for the test. So normovolemic hemodilution refers to autologous, is also known as autologous normovolemic hemodilution, or ANH, and basically involves removal of blood prior to the start of surgery with replacement of blood with non-blood containing fluids. And so if this was a jar or a cylinder of blood, you could replace it with non-blood containing fluids. And this allows for patients with this allows for a low hematocrit blood to be lost during the surgery, and then later to be supplemented with blood taken off at the beginning of the surgical procedure, as depicted here by the stored blood with a hematocrit of 45% then being added back into the patient who may have had a hematocrit drop down to 18%. With this hematocrit of 45%, it could bring it up to 25%. So again, this is something that's fairly self-explanatory, but I think it's worth mentioning. There's also an equation for calculation of blood volume and estimated blood volume times the initial hemoglobin minus the final hemoglobin over the average, or if it's an acute bleed, the initial hemoglobin. Basically, this equation can be used to determine how much blood volume you find is acceptable to be lost prior to transfusing a patient. So at this point, I want to go on and show you a few more graphs. Take a look at this. The cost of cell salvage doesn't change based on the number of units that are transfused, as opposed to the cost of red blood cells or packed red blood cells continues to increase with each additional unit that's transfused. Just something to keep in mind. And sequestration, I do want to kind of move on from sequestration to just say a few things about erythropoietin with the time remaining. Erythropoietin can be used. It costs about 1 cent per unit, $380 it would cost for a single dose of about 40,000 units. And the total cost is dependent on the dosing regimen. And we've laid out 2 different dosing regimens that are possible to use here. And lastly, I would talk about erythropoietin reimbursement. It can be reimbursed in various modes based on whether the patient is inpatient or outpatient. And lastly, there are blood substitutes available that I think you should at least be aware of the names for the board review. There's hemoglobin-based oxygen carriers, or HBOCs, and then there are perfluorocarbon-based oxygen carriers, or PFBOCs, which I think at least knowing those names can help maybe clear up a question that might be confusing as far as blood substitutes. So this concludes what I wanted to mention as a general, broad overview. Again, in a 1-hour time period, it's hard to go over all of the hematologic system, but I think this will help point you in the right direction for a lot of the board questions and a lot of the board discussions related to related to hematology. So thank you very much.